So at the end of this presentation, I hope that we will be able to describe ways to support the caregiver, describe ways to protect their health, and to address their caregiver stress. So here are some facts, and keep in mind this PowerPoint was not developed by me. It was developed a couple of years ago, and so my apologies for some older references, but the numbers when I checked appear to be consistent. So informal caregivers provide about 85% of all care to older adults in the US. Persons living with dementia, and you'll see this in the slides, the PLWD, with caregivers have lower Medicare costs than those without them, and the caregivers often face great emotional, social, physical, and financial costs. So we're looking at some serious forms of stress or distress. Most dementia caregivers are women. Over a third of them are daughters or daughter-in-laws, and more women caregivers live with the person living with dementia full-time than do men. So caregivers are the boots on the ground, and Ottenheimer et al. Say that family caregivers, their knowledge, well-being, and sustained engagement with healthcare providers are critical to the success of both medical and psychosocial components of care. That statement that the success of the medical and psychological, psychosocial components of care is the reason for this presentation. The caregivers are the allies to the providers, as the providers are allies to the caregivers. And I suspect this is no big surprise to any of you. It's not like you're all shocked and you're urgently Googling, why is this so important? We know this. This is obvious that the caregivers are the boots on the ground. They're the ones that are watching and getting it done. They are the eyes, the ears, the heart. They're the blood glucose monitors. They're the behavior management. They're the CEOs. They are the CFOs. They're juggling all of these roles, and we have to ensure that they are able to sustain it. And that is quite a task. So I'm going to assume, and I hope correctly, that we're all familiar with person-centered care. I know it's already come up a couple times in the webinar already today, but this is directly tied to the language, the culture, the values, the faith, the orientation, preferences of the person living with dementia. You know, they're facing all of these changes already, and frankly, it's pretty terrifying for them. And so we want to maintain as much normalcy and person-centeredness as possible for the patient living with dementia, the person living with dementia. And so we want to make sure that it's, you know, person-centered and culturally informed. And as a result, we really rely on the caregiver to inform us about that, how we can make that care plan based on stated preferences. We need to continually review, how are we doing? How is this working? Is this care plan indeed person-centered? Can that care be supported by an interprofessional team, a multidisciplinary team, and have one person as the primary or lead point of contact, of course? And with that interprofessional or multidisciplinary team, of course, everyone needs to be on the same page, and communication needs to be clear and routine, and we need that ongoing assessment. For me right now, I have a social worker who checks in with me. We meet every Thursday at 1 p.m. to talk about how is it going, what have I noticed, what changes have been happening, and then here's what I can do, here's what we as a family can do, and here is what we can anticipate for the future. And it has been so helpful, that multidisciplinary process and very person-centered care for my in-laws, but also for me. It's been amazing. So I would like to say that the caregiver is a master juggler. Even if they never learned how to juggle as a child, they have learned quickly how to juggle all of these multiple roles. And we've got the care provider, the care coordinator, information resource, the advocate, the emotional supporter, the quality sentinel, and I will unpack these slide by slide. So the caregiver role, first and foremost, is care provider. That's what we're calling them in this session. And this is the person that provides assistance with a variety of activities of daily living, the ADLs, and the instrumental activities of daily living, the IADLs, depending on the stage of dementia. And we need to ensure safety and quality of life. Just to kind of cover what ADLs and IADLs are for those who are unfamiliar with the terms or acronyms. The ADLs and the IADLs are important for just daily life, but the ADLs are things that we learned when we were little as children: eating, walking, grooming, toileting, bathing, those basic fundamental tasks of living that we learned usually as toddlers. And then the IADLs are things like that we learned as teenagers, like money management. Well, not all of us learned money management as teenagers. I still haven't quite learned it, but we should have learned money management. IADLs would also be driving and housekeeping and communication and cooking and meal planning and medication management and that kind of thing. So the care provider is either doing all of that, the IADLs, or some of that, or assisting the person living with dementia in doing those things. But that is a massive portion, time-consuming, energy draining part of the role of caregiver, is being that care provider. But then care coordinator. This is a complex process. Working with the multiple providers, coordinating care, making sure plans are implemented, scheduling all of those appointments. And it is very complex. It requires taking a lot of notes, developing spreadsheets, maybe using an abacus. I don't know, but it is a very time-consuming second part of the role. And the third role of the caregiver is just gathering all of the information. What are all the medical diagnoses? What are all the medications and the medical equipment and the goals and preferences of the person that I'm caring for? This is so complex. And I'm just going to say, I really like that presentation by Nicole Brandt, the pharmacist, on pharmacology. That was really helpful. I'm going to tell you, coordinating prescriptions, picking up medications, working out all of the organization and timing of the various pills and shots. You know what? It feels very high stakes for me as a caregiver. And I feel like I'm putting together a very complicated puzzle, and there's always just one piece missing, and I can never figure out what that piece is. It can be incredibly overwhelming. And then I think to myself, I have my doctorate, for goodness sakes, and it's a challenge for me. I cannot imagine what this was like for my father-in-law, working with his own Parkinson's and his own medications, and then being the primary caregiver for my mother-in-law with advanced stage dementia. The medication management alone had to have been an all-consuming task for him. It feels like it is for me, and I've got greater capacity and resources right now than he had at the time. So this third piece is also incredibly time-consuming and challenging. The fourth is advocate. As a caregiver, one of the things I find I'm doing a lot is advocacy, having to advocate for the least restrictive opportunities available for a living situation, and observing their safety, but also giving them the respect and the freedom that they deserve, to the extent that it is still safe, because they are first and foremost adults. They're elderly, they deserve respect and dignity. And so advocating for all of those things, but also setting ground rules about time for and type of communication with caregivers, and talking about safety versus autonomy. So there's a lot of pieces there. And then the fifth, and again, I know I'm not surprising any of you by any of these points, but I'm going to get to a portion of this presentation that is a particular passion of mine, and I hope I can communicate it in a way that becomes a passion for you as well. The fifth role for the caregiver is the emotional support, and providing culturally appropriate comfort and support. And the caregiver usually is the one that knows, because they share some sort of history with the person living with dementia, that they have an understanding of what that culturally appropriate comfort and support is. For example, my in-laws have always had gospel music playing in the background on the radio for most of their married life. And so now, what do we have playing in the background? Of course, it's going to be gospel music, because that sound is familiar, it's comforting, it's appropriate for their culture and their faith orientation. They love their grandchildren, have always loved their grandchildren, great-grandchildren. And so we have a video frame that we have set up in our mother-in-law's room that we can email photos of the kids. And so she has a dynamic, moving picture album of all of the people that she loves, also is culturally appropriate for her values around family. We also need to learn to reinforce positive feelings. And how do we do that? I really like the presentation this morning by Douglas Lane, that he really delved into the behavior and emotions of the person living with dementia in all of the changes that they are facing. And so I'm going to just refer you back to that slide deck because it has so much great content. But I think that one of the best ways that we can encourage the caregiver to reinforce positive feelings and to diffuse emotional outbursts is not to remind them of their diagnosis, not to argue with their reasoning, not to remind them of how forgetful they are or any of those things. The best way to diffuse outbursts or emotional distress and to reinforce positive feelings is to step into their reality and just normalize it and say, this must feel really scary. Can we sit down and just kind of help calm ourselves? This sounds really scary, what you're going through. Can we go into the kitchen and have a cup of tea? But just to normalize their feelings, stepping into the reality rather than arguing with it and just saying, this sounds, and then kind of through your empathy and your understanding of how this person functions, you can fill in the blank of what their emotional experience is. And then also the 36-hour day is by far the best book I have ever read on what it might be like for a person living with dementia and for the caregiver. I've never read such a powerfully validating book before about caregiving and about dementia. I continue to encourage folks to read it. I encourage you to read it as well. You probably already have, you're probably already familiar with it, but if you haven't read it, do. It's readable, it's engaging, it's so relatable. I couldn't put it down. I read it for the first time when my grandmother developed Alzheimer's or was diagnosed with Alzheimer's in 2015, 2013 sometime back then. But the 36-hour day, beautiful, beautiful book. So let me see here. Need to make sure I'm on time and on task here. And then the sixth caregiver role is quality sentinel. I love this word, sentinel. It makes me feel like I can wear old-timey like military uniforms and walk around with a bayonet. But what it really means is that I have to be, or the caregiver, the one who stands guard, who watches for changes, reports problems, asks questions, notices the red flags. And yes, caregivers may be overenthusiastic in reporting the problems, but this is high stakes. This is my beloved. This is the person who raised me or who I committed and promised to care for. And so I just need to let you know all the things that are going on. And your patience is always so appreciated, but also it is probably useful to provide education about what is appropriate to report and what to particularly watch for, and just normalize everything else. So how do we help our allies, those caregivers? We all know that this is potentially high stress, this lifestyle, partly because it's not their only role. They're probably parents of their own kids, they're working a job, maybe they have employees, they're running a business, they're managing other relationships, other responsibilities. And so We need to remind them to take care of themselves. And the next set of slides will unpack that and dive a little bit deeper. I just mixed two metaphors, and my apologies for that. We're going to dive a little deeper into some of those ways that we can encourage self-care, but here are a few ways. We can remind them to take care of themselves and recommend respite whenever possible. Can they find ways to bring others in to assist so they can get some rest and some breaks? Encourage them to take classes, assess and treat for depression or anxiety, address family conflict. These are a couple of the ways, but we also need to work with the families because they are always present. And consensus is great, but it's so rare. And getting there is really hard work. I've noticed in caring for my in-laws, and again, I'm sharing this information, I'm talking about my perspective, not as a means of trauma dumping or trying to gain your sympathy, but to just let you know how this is relatable to me as a caregiver, that their other two sons are in Tennessee and Florida. And so I am so grateful that we all get along, but that collaboration is very difficult. And so sometimes as providers, your role is going to end up having to be helping the caregiver create a script when consensus is not available or possible to, help them develop what they're going to say, such as, this is what I'm leaning towards doing with mom. If you disagree, I would like to know how you will help implement a different alternative or a different option. And so being an ally for the caregiver means assisting them in some of these really dicey parts of this lifestyle, which this is. Now, one of the things I wanted to show you is these counseling resources, and I added psychologytoday.com on the top of the list, and we're going to look at that in a second. But there's also Yale's Counseling People with Early Stage Alzheimer's, which is a nice place to begin. Caregiver Family Therapy, Empowering Families to Meet the Challenges of Aging by Qualls, also a great book. I loved Still Alice, a little relatable as a psychology professor, and it's about a psychology professor. Alzheimer's from the Inside Out. I've not read this book, but I've perused it and found it interesting. And then please do send the resources from Alz Connected, the Alzheimer's Association resources, to your caregiver allies. There's an online social networking site that's really great, but also free 24/7 helpline. That phone number, 800-272-3900. You're going to see that number is on Nikki Wagner's identifier on Zoom here on this webinar, and that's a great resource as well. I'm going to try something brave here. I'm going to move this over here and show you psychologytoday.com. Now you can share this with caregivers, but you might also find this helpful for you and your own loved ones. This is how to find a therapist. I'm going to put in 58078 West Fargo. And you can see that there's this long list of lovely blondes who provide therapy. But what you can do is you can drop down for particular issues such as depression, anxiety, parenting, women's issues, stress, or so forth. So we're just going to say depression. And you can drop down by insurance, Blue Cross or Health Partners, or let's say Medicaid. And you can drop down by age. Let's say we want to specify elders. And if let's say we're referring maybe psychological resources for our Spanish speaking caregiver, you can drop down by ethnicity, sexuality, language, even faith. And so this is a particularly valuable resource that I want to encourage you all to have on hand. Keep a Post-it note handy. So when somebody says, I need to talk to somebody, I just don't know how to find anybody, you can say, I do. And there you have it. So this is actually all over the United States, and you can even refer people in other countries as well. So great resource, and I hope you find it helpful. So assessing the caregiver, we need to recognize that they're dealing with a lot, and we need to look for signs of caregiver stress. And so we have a number of really useful tools here from the APA, from Health and Aging. The Oxford Academic Health and Social Work resource is a great one, but I think it's only for social workers. I could not access it, but you can access it with your NASW membership. And then there are a couple other caregiver stress checklists available. And these are for the caregiver, multiple assessment resources, and these are just a few. And so you'll have these available to you in your PowerPoint download as well. But these assessments should be relevant to identifying the needs and preferences of both the person living with dementia and their caregiver, but it is specifically towards the answers of the caregiver, and they can do these on their own time. The ones I showed you have been periodically updated, and it's important that we identify strengths and deficits or problems, and again, should reflect culturally competent practice. And so these are some really great resources on that previous slide. I really strongly encourage stress management skills, promote support groups and self-help groups. I have got to say that a support group is one of the most beneficial resources that I have been able to suggest, because there's that shared narrative. When I am in a part of a support group, I hear other people telling my story, and I didn't know that it was such a shared story. It is incredibly validating and normalizing and helpful and empowering. And so I strongly recommend support groups. And in a previous slide in those resources, there is access to an online support group. Also encourage them to make their own health a priority and always screen for depression. How are you eating? How are you sleeping? How's your mood been lately? And so you're assessing for depression and anxiety, but also stress. Now, these come from the Alzheimer's Association website on the caregiver stress page. And keep in mind, these top 10 signs or symptoms can be either a cause for stress or the result of stress. So one is denial about the disease and the effect the disease is going to have on the person who's been diagnosed. That denial is a powerful defense mechanism. It serves a purpose, but it has to be, that defense mechanism has to be lowered, because denial does not serve the person well in the long term. Anger. We're talking about grief reactions here, aren't we, on Kubler-Ross's stages of grief, starting with denial and following is anger. And sometimes the anger is directed at the person living with dementia, frustration with them because it feels like they know how to do these things and they aren't doing these things. And that frustration is real. It's significant, but also that anger has to be diffused appropriately. Social withdrawal from friends and activities that used to make the person feel good. This is a sign of depression, that social withdrawal, partly because nobody gets it, nobody understands also who's got the time, who's got the energy. And so one of the things that is sacrificed is that social connection. There's also anxiety about the future, facing another day. How am I going to handle it if it gets worse? Depression, because this can be back-breaking and spirit-breaking work. And depression can affect our ability to cope. The stress of caregiving can affect our ability to cope, and that can lead to depression as well. So it's circular, isn't it? Exhaustion, that makes it nearly impossible to complete necessary daily tasks. And that also can be due to sleeplessness related to depression or anxiety, or it could just be exhaustion from the bulk of work that the caregiver has been assigned. And then sleeplessness caused by a never-ending list of concerns, irritability that can lead to moodiness, negative responses and actions, lack of concentration that makes it difficult to perform familiar tasks, health problems that begin to take a mental and physical toll. This is a significant list of signs or symptoms of stress. But I wonder if maybe these are actually referring to burnout. Stress and burnout are similar. One may lead or feed the other. Stress is usually short-term, and it's caused by that feeling that something is out of control. However, when the situation changes or the situation disappears completely, the stress will lessen or disappear completely. You know, I see this with my students at the university. They're stressed out about finals. As soon as they take their finals, their stress has gone away for the most part. But burnout is different. It is extended. It is a result of ongoing stress, cumulative stress, chronic stress, intense stress, or unavoidable stress. And burnout causes a lot of those signs and symptoms that were on that previous list: sleeplessness, social isolation or withdrawal, irritability, anger, and so forth. So we have stress, we have burnout, and then we have compassion fatigue. And compassion fatigue is more than burnout. It's a combination of burnout paired with secondary trauma and or vicarious trauma. We develop it when we work with a lot of hard cases, when you have a high stress caseload or workload, also results from ongoing exposure to global crises. Yeah. And compassion fatigue can occur on a personal level when you are caring for a loved one living with dementia. And so it is fatiguing. So I want to talk about self-care, and I'm going to look at it through this Maslow's hierarchy of needs. I'm going to rest on this slide for quite some time and just talk about it. I want to discuss this through the lens of self-care. Now, when I talk about self-care, I'm not talking about mani-pedis and massages and dark chocolate, which are lovely. I'm not dismissing them, but while those are certainly nice, care is what our caregivers are providing the person living with dementia: physical care, safety, love, assurances, and so on. So when we encourage our caregivers to engage in their own self-care, and when I encourage you to engage in your own self-care, beloved friends, I want you to do the same. I want focus to be on physical care, safety, love and belonging and social connection, assurances, respect, and so on. So just going to do a quick cursory overview of what some of these things are. So physiological needs. Are you breathing? Are you holding your breath? When I'm stressed, I hold my breath. I start to hyperventilate a little bit. Hydration. Are you drinking enough water, or are you subsisting on coffee in the day, during the day, and wine in the evening? I know who you are, Brenda. Elimination. Are you letting yourself use the restroom when you have to, or are you holding it all day and putting pressure on your bladder or bowels? Are you eating nutrient-dense foods at least 75% of the time? Are you exercising, moving your body? Are you getting sleep? Are the caregivers, a good question, are you taking time to shower? Are you giving yourself opportunities for good hygiene? Are you taking care of your shelter? Are you changing the light bulbs and clearing walkways and things? Are you taking care of your shelter? Some of us have deep nature needs. We need to pet an animal. We need to feel that fur in our hands. We need to go outside and smell the fresh air and feel the sun on our face. Are you meeting that need? Do not dismiss it as just a want or a desire or a privilege. No, for some of us, nature is a need. Comfort is also a need, my friends. When I was doing my doctoral dissertation, I did a program outcome study for the state of North Dakota's Department of Corrections. And so I was evaluating a program in the prison system for North Dakota. And I would go into the prison setting and interview repeat offenders. And I noticed that one of the ways we punish our criminals is we remove all forms of comfort. You walk into a prison and it's all overhead fluorescent lighting. It's slightly chilly. Everyone is wearing scrubs, basically. They are not given soft places to sit. The beds are thin mattresses. If they want to sit and watch television, they sit on a hard plastic stool with no back. When they are eating their meals, they are sitting on hard plastic stools with no back. There is no place to seek comfort. That is how we punish our criminals. And sometimes that is how we punish ourselves, as we refuse ourselves comfort or pain relief or physical touch. So these are physical needs. And as I'm listing these, I'm guessing there's probably one of those things that stands out to you and you're thinking, oh, I should probably do a little bit more of that. Safety needs. We think of external dangers like community violence, but there's also domestic violence, physical, verbal, psychological. There's also other forms of safety we may need to observe, like passwords and digital risks. When my husband passed away, I would say, they say you can't take it with you, but the one thing apparently you can take with you is all of the passwords, which was my very painful experience. I still have one account I cannot access. But those are external threats of safety, viruses, disease, tripping, accidents, that kind of thing. But there are internal dangers that we are not necessarily safe from, like perfectionism, unhealthy boundaries, negative self-talk, comparing ourselves to other people, unhealthy coping. Maybe we're not safe because we are from ourselves because we are abusing our bodies with alcohol or other drugs or substances. Maybe we are abusing ourselves with other impulse control issues like gambling or retail therapy. But all of these are ways that we are threatening our own safety needs. And self-care would be to maybe change one of those things as an act of nourishment and an act of safety, self-care. The next level, now Maslow would say that our first needs, our basic needs are physiological, are physical. Yes, if I'm hungry and I'm dehydrated, I can't be really thinking about self-actualizing unless I'm Gandhi or Mother Teresa, but I'm not, I'm Melissa. And so if I'm hungry, I need to feed me before I can even think about, changing a light bulb. So Maslow said physiological needs are our basic primary. And once those are met, we can then begin to attend to our safety needs, making sure that we are safe from physical and emotional threat. And then we have love and belonging needs. We punish our inmates also by withholding this social isolation. If somebody acts up in a prison, they get thrown in the hole. They are excluded and isolated from their friends. They're allowed to be outside 1 hour a day. Otherwise, they are in isolation the rest of the time. And so when we socially withdraw, when we self-isolate, it is an act of punishment. We have a deep, deep need, my friends, for social belonging. We have a deep need to belong and to one other person, to be significant to at least one other person. And so my challenge to you on this level, and for you to ask your caregivers, not where do you fit in, but where do you feel you belong? And can you do more of that? Can you seek out those people to whom you belong, who accept you, who love you, who make you laugh, who take you to account, call you to account, who don't put up with your BS? Who is your tribe? And can you spend more time with them? Make it a priority. It is a deep fundamental need. I'm going to tell you a really sad story. Some of you may have already heard this story, but this is a perfect example of what kind of happened to us during COVID when we were all sheltered in place and some of us were very isolated, particularly our elderly. Back in the early 1900s, we had foundling hospitals in the UK and here in the United States, and they were basically hospitals for infants that came from mothers who were unwed, unprepared, unable to care for their babies. And so they would bring these babies to these foundling hospitals. And the doctors were well aware of the threat of viruses and bacteria. And so the doctors insisted that all the nurses would wear full PPE, hats, masks, gloves, gowns, aprons. And so they were completely covered. And because they believed in the blank slate theory of attachment, the doctors also encouraged the nurses to not make eye contact with the babies. So the babies' full physical needs were being met. Their safety needs were being met. They were being fed. They were being burped. They were being changed on a schedule. All of their physical needs were being met. Their safety needs were being met as well. They were in cribs with walls and bars. They didn't have fall risk or anything like that. But the mortality rate among these infants was close to 100%. These babies were dying because despite their physical and safety needs being met, their love needs were not. They were not getting the eye contact and the physical touch that they needed to survive. So they literally died from a failure to thrive. My friends, we have a deep need for love and belonging. This esteem needs and self-actualization needs, I'm just going to address very quickly. Esteem needs are doing the things that you're good at, feeling independent, feeling competent, receiving respect, having your dignity honored. And these are things that sometimes we fail to provide the person living with dementia. And sometimes the caregiver fails to acknowledge their own need for this as well, their own need to be valued and respected and esteemed and listened to and acknowledged and so esteem and self-actualization needs are met through doing things that bring us pride, make us feel good about ourselves. I want to talk about how to, one other way to meet these needs, and this is through laughter and humor. I am a certified humor professional, and what that means is after I got my doctoral degree, I got my doctorate in clinical and forensic psychology. And then I thought, you know what? I want to do something fun. And so for 3 years, I studied the applied and therapeutic benefits of laughter and humor. It was a 3-year set of courses that I completed with then another thesis that I had to write. And there are physical benefits of laughter and humor. You'll be surprised. Laughing for 10 minutes burns 40 calories. You're welcome. If you laugh 100 times in a short period of time, it's the equivalent of 10 minutes on a stationary bike. Laughter reduces the experience of pain. It reduces inflammation. Laughter enhances T-cell functioning. It boosts our immune system. It reduces cortisol and catecholamine, which are stress hormones. It is linked to healthy function of the blood vessels. It is related to vasodilation. It has great physical benefits. There was this gentleman named Norman Cousins. Excuse me a second. Norman Cousins, he developed a very rare disorder, autoimmune disease that attacked his nerve endings. And it was extremely painful, and morphine was not even cutting it. It was terribly painful. And so he checked himself into the hospital, and he had read a book about how negative emotions can cause illness. And so he thought maybe positive emotions could cause increased health. And so he decided to focus on laughter and gratitude as his 2 positive emotions. And for the laughter, called his friend, who was Alan Alan Funk. Anyway, the producer of Candid Camera, which is a show back in the 70s where they would basically prank the public for all of our general amusement. And so his friend brought in reels of Candid Camera into the hospital room, put it on a projector, would project it onto a blank wall, and they would sit and laugh hysterically. And Norman Cousins found that 10 minutes of sustained laughter would bring him 2 hours of pain-free sleep. Cancer Center Treatments of America have laughter clinics. Pain clinics out in Los Angeles have laughter yoga as part of their treatment protocol. So laughter actually does decrease inflammation, and it helps us with pain. But there are safety benefits as well. We feel safer when we're around somebody who makes us laugh. It decreases tension in relationships. It's useful in negotiations and conflict management. It shows others you are non-threatening. In some tribal cultures, it's the clown who is the only one welcome to the other villages. So there is safety in humor and laughter, but there's social benefits too. It's like a social lubrication. You know this when you're talking with somebody and you're just getting to know them. If you can laugh together, you feel more at ease. It reduces tension. It reduces anxiety. But it's also really good in interpersonal conflict. Like I said, it helps us manage negotiation. It communicates credibility. It establishes trusts. It creates great cohesion. Yakov Smirnoff, who was a Russian stand-up back in the 80s, he just earned his PhD from Pepperdine University, and his dissertation thesis is that the loss of laughter in a marriage is like the canary in a coal mine, and it signals the demise of the relationship. And so we know that healthy relationships have humor and laughter. And as far as esteem and self-actualization, it allows us to gain perspective. If I have a problem, it sits right here. Let's say I'm stressed about finances. All I can think about is finances. I'm losing sleep about finances. It's just right here. And I can't see anything else but just this blurry vision of problem. But if I can find a way to laugh, and it doesn't even have to be laughing at the situation, but if I can find a way to laugh, suddenly the problem isn't so close to my nose. Now I have perspective and clarity, and I can see the details. Also, I have peripheral vision and objectivity and context. Laughter helps us gain perspective. It is absolutely valuable. A friend of mine, she did her doctoral dissertation, and the title was "The Use of Humor as a Defense Mechanism During the Holocaust." She was doing her dissertation out at the University of Tel Aviv, and she interviewed a number of elderly members of the community who had been teenagers or young adults during the Holocaust. Holocaust being the ghettos, concentration camps, or death camps. And she asked each one a single question. Name a time when you saw or used humor during the Holocaust. One woman shared this story, and I'm just going to share it verbatim from Chaya's dissertation. This woman was a young woman and apparently had been very stylish in her previous life before the Holocaust. She said, after they cut my hair off in the camp, suddenly I saw some girlfriends of mine that I'd known for a very long time. You couldn't recognize them. And then I started laughing. I don't know. Many cried. They cried after their long hair. And then I started laughing. And they asked, "What, are you out of your mind? What are you laughing about?" I said, "This I never had before, a hairdo for free? Never in my whole life." And I still remember they looked at me as if I was crazy. I started asking them, "Who did your hair?" I was used to Misha. He was my hairdresser back home. I said, I couldn't get an appointment with him, but this one was, he was good too. Isn't that great? Somebody else answered, "Look, without humor, we would have all committed suicide. We laughed at everything. We made fun of everything. What I'm actually saying is that humor helped us remain human, even under hard conditions." So there is definitely value in laughter and humor. I find it absolutely valuable in my own relationship with my in-laws. I carry little devices around with me like this. My mother-in-law thinks this is hysterical. When I put this on and then ask, what's smelling? What's stinky in here? She giggles like crazy. Or if I'll say, oh, let me take a look at that, I'll put on my glasses and then I'll look very closely at whatever is on her hand or whatever. And she just thinks it's hysterical. We dance together in our chairs, her in her wheelchair, mine, I in my chair. We watch silly children's shows that are easy to understand, and we laugh. And let me just say, there is nothing sweeter than the sound of her laughter. And so my point is that please, can we integrate more of laughter in our own life? And can we encourage our caregivers to engage in more laughter and humor in their own lives? How did we do this? I just have a couple of suggestions. Hang out with funny friends, play a prank on someone. I gave my in-laws a card, a Mother's Day card. I gave my mother-in-law a Mother's Day card that had googly eyes on it. And my father-in-law took it and put it on one of the plants, leaves of one of the plants. It's just hysterical. So play a prank on someone. You can share a funny meme on social media, share funny jokes with coworkers, watch funny fails or blooper videos on YouTube, create a funny sign for the workplace. I went into my faculty lounge at lunchtime and there was a sign somebody had put on the refrigerator that said, please date your food. And somebody had written, I can't, I'm too busy dating my wife. There you go. So just find ways to find humor in your own life and encourage your caregivers to do the same. So other ways to reduce caregiver stress: educational programs, skill building programs, family therapy, individual therapy, speaking with a counselor, clergy member, and engaging in laughter or play with their loved one. And we always want to ensure that these are culturally sensitive interventions and that we are attending to the caregivers' cultures and understanding that that's going to influence their help-seeking behavior. We know a lot about our own cultures. We don't know much about others. And so we want to become as well-versed as we possibly can. And one of the best ways to do that is to ask the caregiver about their cultural values and norms. And so we want to find ways to employ cultural tailoring to make every intervention relevant for them. So in conclusion, I want to give some time for question and answers. Our caregivers are valuable allies in caring for the person living with dementia, and we need to involve them in all of the care discussions and support their roles and responsibilities. We need to help them protect their own health and proactively refer for stress and depression.